Our presenter today is Professor Benjamin Anyanwu. I'll be asking the president to give a short opening remark before I read the citation of our presenter for today. Thank you very much. Over to you, Mr. President.
Yeah, thank you very much. Thank you, Dr. Salami. Today we are privileged to have one of our very best, Professor Benjamin Anyanwu, talk to us on a topic that is very dear to his heart and to our hearts as well. I want to welcome everyone to this platform. From a little study we did in Port Harcourt, we found out that neurological cases actually, they actually are the majority indications of medical cases that are actually present in the ICU. And stroke is the leading cause of patients who are admitted to the ICU for neurological reasons. And then we know the outcome. And most of the stroke cases that come, they come in, just manage the secondary brain damage that actually occurs. So basically, today we want to hear from an authority in this field, who is our member, who is very enthusiastic about this issue and wants to talk to us. So may I implore everyone to listen very carefully and allow him to empty himself to talk to us. It's an academic exercise with a lot of practical experiences that he will share with us. May we all mute our systems so that we'll have the right audience, for Professor Anyanwu to talk to us. Thank you very much, everyone. Our immediate past president, you're welcome, and all our colleagues, both those in internal medicine, anesthesia, and then those in critical care as well. So I hand you over to our guest speaker, Professor Benjamin Anyanwu, to talk to us. Dr. Salami, you can read out this citation, and we will have a beautiful evening today. Thank you.
Thank you, Mr. President. I'm saying good evening again to all my mentors and my teachers in the group. Good evening, sirs and profs. I'll be reading the citation, the short and brief citation of Professor Benjamin Anyanwu. Professor Benjamin Anyanwu is the Executive Medical Director of Regions Healthcare, Hospitals and Specialist Clinics, Owerri, Nigeria, a United States trained neurologist. He's triple board certified in general neurology, vascular neurology, and neurocritical care. His early career included teaching of neuroanatomy and clinical skills at St. George's University School of Medicine, Grenada in West Indies, and he continued while in the United States. He has participated in several clinical research projects over the years, including the ATTACH-1 and 2 trials, and many landmark international trials. After over 20 years of clinical practice in the United States, he returned to Nigeria to establish Regions Healthcare, a leading multi-specialty center in Imo State. While in the US, he served in several key leadership roles, including the clinical flagship and medical director of the Novant Health Comprehensive Stroke Program, the medical director, Neurocritical Intensive Care Unit, and chairman of neurosciences at the Novant Health Fawcett Medical Center, North Carolina. Professor Anyanwu pioneered the Regions Stroke Alert telestroke program, providing neurological and stroke consultations to hospitals across Nigeria through telemedicine. His work has earned national recognition, including the NHEA Special Recognition Award of June 2024, the NMA Distinguished Service Award, and the National Diaspora Merit Award in 2025. He was also appointed Professor of Clinical Medicine and Neurology at Imo State University in June 2025. He is widely recognized as a leader in stroke care, global health, and healthcare administration. kindly welcome with me this afternoon to a master of the heart in this discipline, Professor Benjamin Anyanwu, MD. Thank you, sir. You are welcome to today's webinar.
Thank you very much. I'm delighted to be here, and I'm hoping that everybody can hear me. Is that correct?
Yes, sir. You are audible, sir.
Good. And thank you for reading that citation. When people, even up to last week, somebody sent through somebody, what does Professor Anyanwu, what is his specialty? Well, my primary specialty in the US, where I trained in neurology. But as you guys know, you can be a neurologist and ultimately be even an orthopedic surgeon if you wanted to. You just have to do the fellowships and the training associated with it, whatever you want to do. So I'm further trained in what is called vascular neurology, which is really, if you kind of summarize it, like stroke, but it's beyond that because you learn more about interventional stuff around neurology and stroke. You learn about echocardiogram, how to perform them, how to do them, carotid duplex ultrasound. You also learn quite a bit of neuroimaging, and I actually did a fellowship in neuroimaging, but did not certify in it because it seemed as if I was doing too many things, and I needed to cut down. And then I did critical care, neurocritical care, and just like here in Nigeria, we also had cases, both neuro and medical, medically ill patients in our ICU. So that makes me an all-rounder, and that's why some people get confused as to why is he talking about hematology, and also talking about obstetrics and gynecology, and still he's talking about general medicine and radiology. So that kind of summarizes who I am, and I'm the executive medical director of John's Healthcare Hospital and Specialist Clinics. We're better known because of our early experience and, of course, being identified as the stroke center. We used to answer Region Stroke and Neuroscience Hospital, but since then, we have gone stroke. A lot of people who work with us, especially critical care. A few of you have seen our ICU, and it's a multidisciplinary ICU, including cerebral cardiovascular, stroke, medical, and renal ICU. However, today I've been asked to talk about a topic dear to me, which is intracerebral bleed, current management concepts. I'm going to approach today's presentation a little bit differently. And I'm hoping that at the end of it, I can actually have the participants go home with something that they can apply in their practice, that can change their practice, and not just some exoteric information describing what is intracerebral hemorrhage and the pathophysiology and all of that. Of course, I'm going to mention that, but I'm going to very quickly focus on the care of these patients as it relates to those of us who are on this forum, the intensivists. So we know, as a matter of introduction, that bleeding in the brain, intracranial hemorrhage, is distinct from intracerebral hemorrhage. So when you bleed into the brain parenchyma, it is an intracranial or intracerebral hemorrhage. When you bleed in the extradural space, it's called extradural hemorrhage. All of these hemorrhages are within the cranium. And as you can see in this slide, an intracranial hemorrhage will include the extradural hemorrhage, like epidural hemorrhage, subdural hemorrhage below the dura, and then intraparenchymal hemorrhage, which is intracerebral hemorrhage, and intraventricular hemorrhage. So if you notice, I've been asked to talk about intracerebral hemorrhage, and I've described for you what is intracranial hemorrhage. And therefore, we're going to focus on intracerebral hemorrhage, also called intraparenchymal hemorrhage, which is that one you're seeing in the arrow, if you can see my arrow move. So what can lead to intracerebral hemorrhage? In general, there's a big umbrella called spontaneous intracerebral hemorrhage, meaning there's no relatively identifiable pathological cause. It just happens. And most spontaneous intracerebral hemorrhages are as a result of hypertensive hemorrhage due to chronic hypertension. But there are other things that can cause intracerebral hemorrhages, such as arteriovenous malformation or AVMs, cavernous malformations, cerebral aneurysm, which most of us are conversant with, dural fistulas, cerebral amyloid angiopathies, and of course, primary and secondary neoplasm. For the purposes of this presentation, we're probably going to focus on the first one, which is spontaneous intracerebral hemorrhage as a result of hypertensive hemorrhage. But it's also important as an intensivist to know these other ones, because, for instance, a young person who is in their 30s or even 20s with a spontaneous quote hemorrhage in the brain is likely going to be, probably depending on what it looks like in an image, from an AVM, which is arteriovenous malformation. Of course, it can be from cerebral aneurysms, and you should be able to identify these two things from history and from imaging, because it's key for you to intervene and manage these patients appropriately. So, an example of just going through some of this is a quick history. Let's look at some history that help us. So this is a 58-year-old male with long-standing hypertension who developed sudden hemiparesis. The CT scan shows the basal ganglia hemorrhage. You would infer that the commonest cause of this type of intracerebral hemorrhage would be because of hypertensive intracerebral hemorrhage. Note that despite the fact that they have a long-standing hypertension, studies have shown that in people younger than this age, usually around 45 and less, you also need to consider other possible etiologies for these types of hemorrhages. Another case is a 75-year-old female presenting similarly with intracerebral hemorrhage, but no significant history of hypertension. This would make you think that the patient may have other reasons to have bled in the brain, such as amyloid angiopathy. Amyloid angiopathy is typically seen in more elderly people than in the younger folks. The patients typically may not have any significant history of hypertension, and it tends to cause what is called lobar hemorrhages. And if you do an MRI on those patients, you're going to see these multiple areas of hemorrhages in the gradient recall echo or the SWI imaging. Very characteristic. This is a 68-year-old male on warfarin and could have been on any other oral anticoagulant, presenting with intracerebral hemorrhage. What you see there is a characteristic CT scan of the patient. And if you look at that, you can see an area of hyperdensity with an area of hypodensity on top. This type of pattern is what we describe as blood fluid levels, and it's very characteristic of bleeding as a result of anticoagulant-related ICH. All of what we described are ICHs, but having an idea the type of ICH you may see in different scenarios is important, because obviously, from what I'm saying, it is anticoagulant related, which, by the way, can also occur even in patients with liver diseases resulting in vitamin K dependent factor deficiency. Then you know how to manage them. If it's because of amyloid angiopathy, the management is different. And from any of those other causes of intracerebral hemorrhages, their management could differ. So, spontaneous intracerebral hemorrhage, in this case, hypertensive intracerebral hemorrhage, which is where we're going to focus our discussion, are a subtype of hemorrhagic stroke characterized by bleeding directly into the brain parenchyma, the cerebrum. That's exactly what I've been trying to describe. Of course, you know, most of us know that there are basically two types of strokes: ischemic stroke, which are non-bleeding, and the hemorrhagic stroke, in this case, spontaneous intracerebral hemorrhage, which are as a result of bleeding into the parenchyma of the brain. The key pathophysiology associated with this is as a result of vessel rupture, typically because of long-standing high blood pressure or hypertension, leading to hardening of the small vessels. When they rupture, it leads to hematoma expansion at the early phase. We say that the hematoma expansion tends to occur mostly within the first 4 hours. With that hematoma expanding, it leads to perihematomal edema formation. This is distinct when compared to ischemic stroke that tends to have a large area of penumbra. ICHs typically do not have a large area of penumbra, but due to perilesional edema or compression of the tissues around. The blood on itself causes secondary neuronal injury, inflammation, and toxicity to the brain tissue, causing further damage. If the hematoma continues to expand and causing cerebral edema, it can lead to possible herniation in severe cases. And most of the patients who die in our facilities here in Nigeria are typically due to herniation syndromes. And hopefully I'm going to tell you how to, what to do to prevent herniation in some of these patients. Another key point I want you to know is the common anatomical locations for intracerebral hemorrhage. Intracerebral hemorrhages tend to occur most often around the basal ganglia. So if you've seen some of these scans in the past, you see majority of them are really around the basal ganglia, but particularly in the putamen. The second most important area that you see intracerebral hemorrhages is the thalamus, marked in that place as C. The putamen is B in that image. Lobar hemorrhages, A in the image, are less common. And when you start seeing lobar hemorrhages, you have to start thinking of something else. If it's an elderly person, even with the history of hypertension, think more of amyloid angiopathy. If it's on anticoagulation, think more that this may be because of the anticoagulation. If it occurs in the gray-white junction, start thinking of maybe that this is a secondary tumor or a primary tumor that is bleeding in the brain. The fourth most important place that you have hemorrhages to intracerebral hemorrhages will be the brainstem, the pons being number one, and then finally the cerebellum. So again, to summarize, the common areas that you see intracerebral hemorrhages, hypertensive intracerebral hemorrhages will be the basal ganglia, most commonly the putamen, the thalamus, lobar hemorrhages, brainstem pons primarily, and then cerebellum. So again, like I said, unlike ischemic stroke that tend to have a large penumbra, and if you don't intervene, either with mechanical thrombectomy or thrombolysis, the penumbra expands. Intracerebral hemorrhage causes hematoma formation. And the injury is because of the mechanical tissue destruction. So on the left is a CT of a patient in the early hours of an ischemic stroke, because the CT is typically normal. On the right, the green arrow is pointing at the early ICH in that patient. Further damage you're going to see will be because of the mechanical tissue destruction. If you do nothing, the hemorrhage expands, which is hematoma expansion, leading to increased intracranial pressure. And then, of course, like I already said, secondary ischemic injury as a result of this. So I've spent some time describing to you the difference between intracranial hemorrhage that encompasses everything, intracerebral or intraparenchymal being the same. I've talked to you about the possible etiologies, and I also have talked to you about how they cause injury. So because I've been asked to talk about treatment guidelines, I'm going to now move over to ICH guidelines. How do you manage ICH? And this is going to be as practical as I can be. Well, as you know, I'm trained in the United States. So I tend to focus mainly on what I know best, which is how I was trained. But I also use mainly US-based guidelines for the management of patients. But I also use the European guidelines. But before I go through these guidelines, I want to lay some groundwork to say to you, what do guidelines do? They are not one glove that fits all. They merely present you or provide you with recommendations, guidelines to guide you. Doesn't replace anything. In this case, remember, guidelines are typically more relevant in the locations where they are made. In this particular case, the AHA guidelines will be mostly for clinical practice in the United States. But these guidelines can be extrapolated worldwide. So you're not going to say, oh, this is just for US people. Well, if we had our own established guidelines based on evidence in Nigeria, we won't even be talking about this. And since we don't have one, pick and choose the one you want to, whether it's the European guideline or the US guideline or the Chinese guideline, but pick something. You cannot practice medicine without having some sort of evidence of what you're doing. Like I said, guidelines are intended to define practice minimum requirements for the patient's needs. They should never replace your clinical judgment. Your clinical judgment, though, should not be based on just your gut feelings. Because I'll tell you one thing I've discovered since I've been here amongst a lot of our colleagues. It is that everybody just does whatever they do or whatever they want to do without some sort of clinical trial or evidence to support it. And it mustn't be the US clinical trial, the European clinical trial. Dr. Job here just described what I've always thought about. There was a study done in Port Harcourt looking at patients who came into the ICU. The fact that a lot of them were neurologic patients, and the fact, of course, that we know that a lot of them were stroke patients. As far as Nigeria is concerned in general, if you extrapolate that information, that should represent what typically happens across the country. Should not replace your clinical judgment here means, for instance, most of the guidelines the US talks about the use of nicardipine and several other intravenous blood pressure medications in the management of blood pressure in acute ICH. But we don't have those medications. So using your clinical judgment, for instance, which is one of the things I do here, of giving, say, sublingual nifedipine, and from my experience, really helps to reduce that blood pressure. It's an appropriate response in our environment. So the AHA guideline, interestingly, was last updated in 2022. They are working on a new guideline now. So most of my presentation is going to be based on the 2022 guideline for the management of patients with spontaneous intracerebral hemorrhage from the AHA, which is really based on a lot of clinical trials and information out there, summarized following several reviews to provide a workable platform or a workable direction for us. Again, like I said, they provide recommendation. Look at it from the context where they are written, but they can be extrapolated. They're intended to define some sort of basic minimum standards and should not replace your clinical judgment. So the next several slides, I'm going to talk about some of the take-homes from that guideline because I don't want to waste everybody's time going through the guideline. And I would recommend that you spend some time during the upcoming week, print these guidelines free online, read through it. We reach in ways that you could never imagine. We learn a lot of things, not just about the guideline, but how it came about, those guidelines, which is really the essence of evidence-based medicine. So in all we do, have the clinical evidence of what you're doing and not just because of your gut feelings. So these are some of the take-home messages. Number one, that there should be an organized healthcare system. Could be regional in our own case, probably in Nigeria, to provide an initial intracerebral hemorrhage care. This should be based on capacity that we have. We know we are limited. And when appropriate, be able to transfer these patients to facilities with neuro-ICU and neurosurgical capability. Holding on to patients with ICHs where you don't have proper neurocritical care, either by having somebody who has this ability or have access, or you can do even teleconsultation, or that you don't have neurosurgical capabilities in the place, is unfair to the patient. We know from this guideline that it leads to increased mortality in this patient. And I believe that a lot of us know this. So I hate when the people say conservative management, watch and wait. It's just a certificate to death in our patients with ICH. The guideline also tells you that if you allow hematoma expansion to occur, it is typically associated with worse ICH outcome, or if you do nothing about it. There are a range of imaging markers that can help you predict the risk of hematoma expansion. And then the first image you need to do, where possible, is a non-contrast CT scan of the brain. It is quick. It tells you blood or no blood. However, if you have a brain MRI within your facility like we do, it is also possible that you can get a brain MRI very quickly within 10 minutes. But it needs to be a special protocol that helps you to see the blood. And the reason why a lot of people find it difficult to do a brain MRI is because it requires a different skill set to interpret rather than a CT scan of the brain, which is, you're seeing that thing that is white, you know, it's blood. If it's not there, you know there's no blood. So I would recommend for most people to do a CT scan of the brain, just like the guideline recommends. Further take-home messages include ICHs, as we know, just like other forms of stroke, are as a result of well-defined vascular pathologies. So there's no guesswork in it. An ICH, because of a tumor or angiopathy, is different from a hypertensive hemorrhage. So this emphasizes the importance of defining the vascular risk factors that cause the ICH. So when you get that patient, try to define what are the risk factors for that stroke, such as hyperlipidemia, hypertension, diabetes, and other such vascular risk factors. When implementing acute blood pressure lowering after mild to moderate ICH, treatment regimens that limit blood pressure variability and achieve smooth, sustained blood pressure control appear to reduce hematoma expansion and yield better functional outcome. The way to look at this take-home is, whatever you're using to control that blood pressure, you don't want the blood pressure swinging. One time is 200, the other time is 140, the other time is 160, the other time is 240, the other time is 180, all over the whole place. We know that from that guideline for management of this patient, that such swings in the blood pressure often lead to poor outcome. And that whatever you have to do, you have to have a sustained and gradual reduction in the blood pressure. We're going to go to recommendation on the numbers you aim to achieve soon. Further take-home messages: ICHs, while anticoagulated, have extremely high mortality and morbidity. So if you have somebody who's anticoagulated presenting with ICH, the chances of dying is very high when compared to people who are not. There are several things we do, such as giving these patients lasers, furosemide, as a means of treating their cerebral edema. It has no benefit, but can be harmful sometimes. Prophylactic corticosteroids is a no-no. And continuous hyposmolar therapy appears to have no benefits. Hyposmolar therapy, such as mannitol. The use of platelet transfusions outside the setting of emergency surgery or severe thrombocytopenia appear to worsen outcome. There are patients who still, when they have ICHs, their doctors pump in platelets, especially if they were on things like aspirin. The guideline is telling you it doesn't help. But if you're going to operate on these patients, especially that things on like aspirin, particularly clopidogrel, it might be helpful. Or if the patient is severely thrombocytopenic. But you don't do this prophylactically. It doesn't help. Another important thing you need to take home here is prophylactic anti-seizure medication. In the absence of evidence of seizure, do not improve long-term seizure control or functional outcome. I say this to people all the time. They say, especially some of the hospitals that we cover, Somebody has an ICH, put them on Keppra, put them on phenytoin. No, it doesn't have. Those things are anti-seizure medications. They treat seizures. They don't prevent seizures. So if your patient has a seizure, give the patient anti-seizure medication. But if they don't have a seizure, don't prophylactically place them on anti-seizure medication. Hopefully you guys can understand the difference between that and what we do in a lot of cases, where just because we see an ICH, we start them on seizure medication. No, what he's saying, seizure medication is okay, but start it only when your patient has had seizure. If they don't have seizure and you start it may not necessarily prevent the seizure, but it can also affect functional outcome, especially things like phenytoin. Another interesting one, take-home message, will be the use of high-tight compressive stocking alone as a means to prevent DVT. We know from the guideline that when used alone is not an effective prophylactic therapy. What you should actually be using will be the sequential compressive device, which is like that boot you wear and then the machine is compressing it gradually and releasing. But we still go to a lot of hospitals and people put this on patients, the stockings, believing that they're helping the patient. No, it doesn't prevent it, DVT. So keep that in mind as well. Furthermore, even when the patients are bad, they meet your DNR when you do not resuscitate. Don't try that patient on. People who are conversant with our practice in regions, we know that there are a lot of patients that have been written off and eventually walk out of the hospital. The reason for that is that hematomas from ICHs, they tend to, interestingly, exert maximum clinical response without necessarily as much tissue damage as you see in the image because of the blood you're seeing. And when managed well, especially early enough, a lot of those patients, especially those with strokes on their non-dominant hemisphere, can do well. And in an environment where life and death means a whole lot, both to the family and to the patient, we're saying do a little bit more and don't write the patient off. Of course, you will hear that you have to carry the patient's family along with you in anything you're doing and in decision making in these patients, so that their care is not misconstrued. If you have a patient with ICH, it is important that you utilize some sort of baseline severity score. We use the ICH score, which is a standard score, which tells us how bad it is, the ICH, from ICH score of 1 to 6, but also tells us how likely the patient is to survive or the mortality associated with ICH score. The ICH score is very easy to calculate. The only impediment on your side will be if you don't know how to read images of the brain, or you can work with your radiologist to read what is called the ICH volume to be able to calculate the ICH score. Rehabilitation is important for recovery of this patient. So it is generally recommended that you start early rehabilitation in these patients, especially those with moderate ICH, usually within the first 24 to 48 hours. At least, even if you don't take them to the rehab center, ask the nurse or their family to start doing stretching and functional tasks and training by the bedside. Plan for your early discharge of these patients as much as you can based on your hospital protocol. Consider antidepressants for the patients, especially I found that in Nigeria, especially the men, They go into depression very, very quickly once they've suffered a stroke, whether ischemic or hemorrhagic strokes. It does happen in women too. Have a low threshold for starting these medications because unfortunately their patients are depressed. It leads to poor outcome, poor recovery because they participate in rehabilitation less. And their outlook in life becomes significantly reduced, leading to poor outcome. And finally on that, like I said, incorporate the caregiver, incorporate the family. In regions, for instance, we try to do family meetings as early as the patient comes. We call the families on a daily basis to discuss with them what's going on. But we also incorporated something that is unique, which we call the manager's administrative rounds. What it is for us, we have non-clinical staff who are in administration walk around and try to meet patients and their relatives and ask them to be sure they know what is going on with their patient. And of course, ask them, find out other problems they may have, including good water. Are they sleeping well? And then report back to the clinicians who hold the clinical questions with them. The most important thing here is to incorporate the caregiver. We've also just recently started a caregiver WhatsApp forum where we now try to get those people who are survivors from stroke and their caregivers and provide them information in that platform. It also helps them to interact. And as we build this more and more, I'll be very happy to share with colleagues across the country and you can add your patients. The basic thing is that it's almost like Alcohol Anonymous, where people talk about their difficulties and how they surmounted it. And then there's just a moderator who just helps to guide that conversation. Having gone through this take-home message, let me take the next few minutes now to create for you treatment guidelines based on order sets that you can use in your hospitals. By the time I finish this, hopefully it will help you have an order set. If you're interested, we can put it in PDF format and send to you. And this is what we use in our hospital. Before I start that, the summary of what I have said is initial evaluation and care system is important. You should treat ICH as a medical emergency because time is brain. Always. Don't waste time. If you can't handle this patient, transfer them. If they refuse to be transferred, document it or give them the option. Rapid neuroimaging, CT preferable, MRI if you have it is important to confirm diagnosis. Care in specialized stroke centers with neurocritical care units per guideline improves outcome. If you don't have one, at least an ICU somewhere or ICU capable hospital, and then ask questions or read a book to be able to know the best thing, the best way to manage this patient. So we're going to go through our order set that I think you can adopt. So the order set, an ICU cannot function without order set policies and protocol. ICUs are not dependent on the machines there. They're not even dependent on how intelligent or how well-trained the doctors are or the nurses are. What makes an ICU function are those policies, protocols, and order set. And I'll just go through a simplified order set that you can adopt if you want. So these are the initial order sets we have here in regions. We either admit them to the neuro ICU or to the stroke unit, depending on how bad they are. These patients are typically placed on continuous telemetry monitors and pulse oximetry. And we usually have either, depending on how bad they are, one-on-one nursing or maximum one nurse to two patients to be able to check their vitals every hour, at least for the next several hours, for the next 4 hours and then 24 hours. The reason why you do that is intracerebral hemorrhage hematoma expansion tends to occur maximum within the first 4 hours and the first 24 hours. So remember, 4 hours, 24 hours. Beyond that, chances of expansion is very, very low. They're going to be dealing with the pressure effects, cerebral edema down the road. So if you can limit that that early hematoma expansion, you would have been able to help your patient. And you can do that probably with blood pressure control, steady blood pressure control. Elevate the head of the bed to 30 degrees. Monitor the oxygen saturation to keep it at least about 94%. Keep your patient's MPO until you do a swallow evaluation. So our swallow evaluations are done by the nurses, by the bedside. And it's simple for you to practicalize that. All you need to do is, of course, the patient has to be awake. If the patient is not awake, you're not going to be doing swallow evaluation. Just put an AG tube. Even that patient who's awake and alert, please do a swallow evaluation. Take a small teaspoon, take water in a cup, put in a spoon, give it to him to swallow several times. If the patient clears his throat or coughs, they cannot swallow. Put an NGT. You would have saved that patient the agony of aspiration pneumonia. Just last year, we presented a paper at the African Stroke Organization in Kenya, Nairobi. In that paper, that the research we did here, we found that the majority of the patients who ultimately die from stroke, both within the ones who come to us and the ones who have been transferred from an outside hospital, die because of aspiration pneumonia. Aspiration pneumonia occurs mainly because we have not done a proper swallow assessment, or we have aggressively tried to feed this patient just because we think they're awake and alert. Being an awake and alert, seeing an awake and alert patient does not guarantee they may not have some element of dysphagia resulting in microaspirations. Please, for all your stroke patients, ICH or ischemic stroke, always do a swallow evaluation and document it. These are some of the relevant investigations we do. Immediately, as soon as you can, distinguish the cause of that stroke and know whether you're dealing with an ischemic stroke or a hemorrhagic stroke. Like I've already said, consider a non-contrast CT scan. If your patient is deteriorating, getting bad, within the first 6 and 24 hours, repeat that CT scan. Why? Because I've told you here, hematoma expansion tends to occur within the first 4 hours and within the first 24 hours. So that is when they will deteriorate more likely. Although at 72 hours, you may have to be dealing with a different factor, which is cerebral edema. So if your patient is changing, repeat that CT scan. It's not enough to say, I've done one CT scan. If they're changing at any point in time, repeat that CT scan, whether it's within the 24 hours or within the first 3 days, 72 hours. You might see something that you can use and help your patient. Where possible, I didn't include here, depending on the age of the patient. Typically, patients less than 40 years in Nigeria, I tend to do a CT angiogram as well to be sure that there are not other things like AVM, dural fistula, or even aneurysms that may have caused that ICA. Because sometimes, of course, we know that aneurysms cause subarachnoid hemorrhages, but sometimes it can rupture into the parenchyma of the brain and look initially like an ICH. Meanwhile, it's an aneurysm that ruptured. These are some of the early labs. CBC, you want to look at the hemoglobin, you want to look at the platelets and other blood indices. PTINR and APTT, you want to see is there a coagulopathy that's associated with worse outcome. Look at the electrolytes, urea and creatinine. This cannot be overemphasized. Check your random blood sugar always and keep your patients euglycemic with normal blood sugar. Do not overcorrect your blood sugar. Group and cross-match these patients earlier on and keep blood available depending on what's going on with the patient, especially if your patient may need surgery. So blood pressure management. The target blood pressure should be anything between 160 and 180. This is based on the Interact-2 and attach 1 and attach 2 trials. I participated in both the attach 1 and attach 2 trial, which was a randomized trial that looked at blood pressure management in patients with ICH, mainly in the United States, but also outside the United States, and found that this patient did slightly better if their blood pressure was controlled in the acute period we're talking about. If you have IV options like hydralazine and labetalol, please use. We don't have the calcium channel blockers IV form that is used abroad. So I use mainly labetalol or hydralazine. And when this patient comes, one of the things I do is to open the back of their tongue and drop 20 milligrams of nifedipine. I found that it helps to reduce that blood pressure gently. Remember, the key here is to make sure your blood pressure is not going up, down, all over the whole place. You want a steady but slow blood pressure control over time. It leads to better outcome. Avoid in that early stage decreasing your blood pressure less than 130 millimeter mercury. The reason is that you still want some sort of cerebral perfusion. So below 130, cerebral perfusion pressure becomes a problem in these patients, so you don't want that. If they're on anticoagulants, we don't really have 4-factor PCC, but please, for hypertension, consider at least vitamin K, IV in this people. Run it slowly. But the gabatran, factor 5, factor 10 inhibitors, if you have the PCC, fine. If you have any other medication, please use. If the patient is on antiplatelet therapy, no antiplatelets unless surgery is planned in this patient. Do not use antiplatelet therapy prophylactically. If you're suspecting that a patient may have cerebral edema, how do you diagnose this? You diagnose it based on looking at the CT scan. So not everybody who comes with ICH has to be on some sort of osmotic diuretic or hypertonic saline, or has raised intracranial pressure. I had one of my senior registrars that is doing a one year's long rotation from a hospital in Anyanwu here with me, one of the teaching hospitals. And he had not too long ago a patient with encephalitis. He was telling me that he has to put him on monitor. I said, for what? He said, that's what is always known. That's what they do. I said, for what? What does monitor do? What are you going to achieve? He said, cerebral edema. I said, look at the MRI he did. Is there cerebral edema there? No, sir. Well, I didn't know that. So it's not everybody you see, boom, they're on monitor. In fact, putting those patients on monitor earlier on than they need it may limit the effect of monitor in these patients. Hypertonic saline is an option as well. If you have it, it's available in Nigeria now, thank goodness. What I do in my practice here is that I combine mannitol, low dose mannitol, typically about 12 to 25 grams, given every 6 to 8 hours. And then I put this patient on hypertonic saline, about 60 cc every hour, running as an infusion. And then I hold the hypertonic saline. I monitor the serum sodium every 6 to 8 hours, but you can do that every 12 hours. But once that serum sodium is about 150 or above 150, stop the hypertonic saline. Because if you don't, when it's at 150, 152, by the time you check it again, it will be 160, 170. So I hold for serum sodium equal to or greater than 150. But I check my serum sodium at least every 8 hours. Usually I do 4 to 6 hours. But every 8 hours is okay. But if you are limited, at least check it every 12 hours. 60 cc of hypertonic saline is a safe dose. Ideally, you should go higher. But why I use hypertonic 60 is avoid pushing the patient to severe hypernatremia. And then I use mannitol at a dose, not just hang one bag of mannitol or 2 bags of mannitol. So the dose I use is usually about 12.5 grams, depending on how bad the edema is, to 25 grams every 6 to 8 hours. So you need to write it down. That's basically what I mean. Do not use corticosteroids on this patient, whether it's dexamethasone or methylprednisone. Please don't use. It causes more harm. It does not help this patient. Always get neurosurgeons involved as early as possible. That doesn't mean they have to do surgery. There are indications for surgery. The indication includes cerebellar hemorrhage greater than 15 cc. The brainstem compression, they may be able to do decompression, especially of the cerebellum, by doing suboccipital craniectomy. Neurological deterioration, sometimes they may have to go in and do hematoma evacuation. Hematoma evacuation works best if the hematoma is about 1 cm the surface of the brain. But the other things we do also in our place. The cerebral edema is so bad, the neurosurgeon can go and remove the skull in that area, which is hemicraniectomy. They don't touch the deep-seated hematoma, because the more you go to the basal ganglia and try to remove the blood, it's associated with actually poor outcome. So they just do a hemicraniectomy. You remove the bone in that area, bury it in the stomach, and then allow the brain to expand. There's some other thing they do, which we have not had a good success in, which is they do a hemicraniectomy, but they don't remove the cranium. They leave it there as floating. My experience is that initially it can provide you with some sort of feel-good experience, but after a while, I found that thing not to be helpful. So I usually recommend that my colleagues, the neurosurgeons, remove the brain, bury it in the peritoneum, and then when the patient does better within the next 2 to 3 weeks, 1 month, sometimes 6 weeks, 8 weeks, they do surgery, take it out and put it back. Most neurosurgeons can do this. They consider external ventricular drainage if the patient has IVH or hydrocephalus. For seizure management, treat only clinical seizures. The PRN anticonvulsant here means when the patient has seizures. The drug of choice I typically use is levetiracetam. The reason is that it has minimal or no interaction with other medications you might use in these patients, especially if on antibiotics. But remember, levetiracetam will not be a drug of choice if the patient also has renal impairment because it's renally excreted. In that case, I often use phenytoin. On the other hand, phenytoin can be associated with poor neurological progress and should not be used with patients with liver disease as well. And in this other set, you can see no routine seizure prophylaxis is allowed. Treat only when you have seizures. Our DVT prophylaxis, we use intermittent pneumatic compression. We started immediately, not the stocking. The stocking doesn't work. Use the intermittent pneumatic compression. There's something I've never really tried, but you should probably do a randomized trial in your place of wherever you practice. Because how does pneumatic compression work? It massages the thighs, the thigh muscles. Maybe if you don't have this, you can ask your patient's families to massage the calf continuously while they're by the bedside. At least most of us are lucky that based on the way our hospitals are arranged, or based on the, I don't know if it's law, have patients by the bedside. Ask them to keep on massaging the leg. Who knows? I have not tried this, but I would recommend this if you don't have intermittent pneumatic compression. Even if you have to put that stocking, ask your families to continue to massage the calf muscles, and then see if there is an increase or decrease or no change in the development of DVTs. I know it sounds crazy, but usually within the first 48 hours, we start low dose heparin. So we start Clexin, 40 milligrams once daily. It will not cause that hematoma to expand. I know everybody's scared. It will not. Usually 2 days after. The US is a little bit more aggressive, but we do 2 days after. We are better off preventing that DVT that may lead to fatal pulmonary embolism than allowing it to be there. So other supportive care we typically do is blood sugar control. We make sure the blood sugar target is normal. You don't want to over-treat it. Treat fever if the patient's temperature is above 38. Do the swallow assessment, which I had talked about, and start enteral feeding per oral within the first 24, 48 hours if the patient passes swallow evaluation, if not put an AG tube. The family may not like it, but you're saving them horrors. You're saving the patient's life. Long-term blood pressure control. Usually I start this gradually after the first 7 days, or gradually over the next 7 days. Should be a target of systolic blood pressure less than 130 and diastolic less than 80. Typically, if patient needs anticoagulation starting from about week 7 to week 8. That's full dose anticoagulation we're talking about. We avoid NSAIDs in the early days of management of this patient. And of course, address risk factors, hypertension, diabetes, smoking, and other risk factors the patient may have. The standard goals of care will be to discuss prognosis with family, like I said, avoid any early DNR, but be realistic. And found out that based on our cultural values, especially those in the South, where we expect that no matter what happens, the patient is going to live, and also because we believe that prayers can cure everything, it's important that the intensive is to be as realistic as possible. If possible, I'm not recommending this, but if possible, of course, you have to tell the patient the truth. Paint a more unrealistic, meaning a more grave picture. Because mortality associated with ICH is very high, even when they look fine initially. If the patient leaves, you become the hero. If you have done everything you have to do and something happens, at least you set the family a realistic goal. Or do everything for these patients and don't give up on them. Finally, early physical therapy and occupational therapy consult is important. Typically within the first 24 to 48 hours in patients with moderate hemorrhages. In patients who, of course, were intubated and all of that, of course, you can still start that, but passive therapy in the bed is also important. Mobilize your patients as soon as possible. With this set of other sets that we use here that I've presented to you, starting from, of course, etiology of and description of intracerebral and intraparenchymal hemorrhages, and then ending up with the other set. I will say thank you, and I'll be happy to take questions if you guys have some. Thank you. Question.
Thank you very much for the wonderful presentation. Can now take questions. Can send your question to the chat box, please, or you can raise up your hand to be acknowledged to ask your question. Thank you.
By the way, the other set I presented, people who are interested, I will send it to Dr. Job. If you are interested and you can adopt it to an institution, is available. I'm willing to share that. It's simple, but you need to have another set in place. And if you also notice, my approach this time is a little bit different from how I've handled topics in the past. And I'm hoping that we would have been able to be left with something that we can actually practicalize where we are. So somebody asks here, what can be done for patients who have persistent hypertemia, not responding to antipyretics? So let me start answering. So ICHs, and just like other intracranial and intracerebral insults to the brain, can cause what we call thalamic storming. So what you may be dealing with in that case is thalamic storming. So depending on what is causing the fever. Of course, you have to rule out common things, such as infectious causes. But if you have ruled out these things and the person is still having persistent hyperthermia, options, of course, include using drugs. Sometimes we use medications as simple as labetalol that has both alpha-1 and beta blockade. Alpha and beta blockade as an alternative to blood pressure medication for these patients to be able to control, because it's as a result of excessive adrenergic response in this patient. NSAID is avoided because obviously NSAID, just like other medications, basic NSAID like aspirin, are antiplatelet agents and can lead to worsening of hemorrhage in this patient. So somebody says, what do you give if the blood pressure is above? Sorry, can't see that. Quite a lot of questions here. Let me see that. Maybe I ask the moderator to choose these questions and ask, because there are quite a lot of questions here.
Now, the questions are, which of the questions do you want to?
I can answer the question as much as you guys want. Let me just go back here. I was having a problem doing this. So somebody said, what do you think about prophylactic decompressive hemicranectomy? That's actually a very good idea, and I'll tell you why I think it's a good idea. Number one is, I remember in the early days, my early days of practice, and we had to wait for these patients to actually get bad before we started doing decompressive hemicranectomy. And what we found out that these patients, you waited to start showing herniation symptoms, did poorly, and then we converted to doing early decompressive hemicranectomy. If you look at it, it's a large hemorrhage. You suspect these patients are going to develop cerebral edema, then you go ahead and do early decompressive hemicranectomy. These patients typically do better. The problem in our society is, remember, it is easy for people to go out there and criticize what they're doing without evidence. Word of mouth alone can destroy a doctor. The next thing people are going to say, they like to do surgeries even when there's no indication. And unfortunately, the person who's out there talking about you and your practice is not even relating to you or asking you questions. But yes, I recommend it where appropriate and where you have had appropriate discussion with the family to say, these people are probably going to do worse if you had to wait. Somebody said, thank you so much for a wonderful presentation. Please, is there any evidence to benefit of early anticoagulant use? And I said that we think that's prophylactic DVT, not full anticoagulation within the first 48 hours. Yes, there are trials to support that's what you should be doing. And that was why I showed you, I sent you the evidence where it's coming from. Please take your time and review that literature. Can the recorded version be made available to us? That depends on this society. The association has to decide that. I think they recorded this. So somebody says, thanks, Professor Bain, for the concise and lucid presentation, different from a previous one you did something ago at another forum. Well, yes. This is different because I felt that it is better for the intensivists to have something they can actually go home with. This is not trying to teach anybody anything basic. We all know the basic. We're looking for practicalities. How can we make practice change that will help our patients? So somebody said, I'm familiar with 20% mannitol, 300 mils over 8 hourly. Is this an overdosage? Mannitol is dose. There are two ways to dose mannitol: low dose mannitol and high dose mannitol. It is dose per kg. It's not just 20%, 300 mils. No, it's dose per kg. To calculate the weight of your patient, you do high dose is 1 milligram per kilogram per kg. Low dose is 0.5 milligram per kilogram per kg. So it's better you dose your patients per kg, not just the 300 mils over 8 hours. That was exactly what I was trying to talk about. Somebody said, is it proper to assume that onset of fever in ICH is associated with bleeding into the brainstem? It is improper. That is not correct. You actually can have, let me use the word, central fever as a result of ICH. And it's important for you to distinguish that from fever because of infection. And where you have procalcitonin available can help you to do that. Do I think that ICP monitoring will significantly affect outcome? You do ICP monitoring if you think there's a need for you to do that. Most of our hemorrhages, we don't do ICP monitoring because you need to put the ICP probe, which is a bigger problem. But in patients with severe, large ICHs, you may have to do that. Yes, we have the capability of doing ICP, CPP monitoring. And our nurses are trained to adjust the EVD for target ICP, but this is under strictly with the neurosurgeon's direction. So they don't just do it, they call the neurosurgeon before they do anything. This neurosurgeon have to certify you before you can start doing anything. So it's not for all the nurses. Well, somebody says, I didn't hear anything about intubation. Well, I guess the standard rule here remains. If your patient, there's airway compromise, even in the face of a good GCS that we know, intubate your patient. Otherwise, you should intubate patient GCS less than 8. Should be a warning for you to intubate. But check your blood gas. Again, I didn't go into this detail because we're probably going to spend the next 2 hours going through all of this. I'm assuming that we are going to follow the normal ICU critical care management of this patient. So that's why I didn't talk about it. But yes, you have to. If there's airway compromise, if you do a blood gas is not looking well, good, or depending on what is causing it, or if there's rapid deterioration in their mental status, especially if you use their DCS, which is a common thing as a guide. However, remember, early intubation, it's better for you to intubate the patient mistakenly, quote unquote, and then extubate, rather than you are waiting at the last minute and you're struggling to intubate the patient that has airway compromise. It never goes well. So if you have your guide, and I'm saying that your ICU should have its protocol, that was why I said an ICU cannot function without good policies, protocols, and other sets. So you should have your protocol for intubation of patients. We do have that. This is when you intubate patients. And this is how you intubate patients.
Thank you very much, Prof, for your. I don't know if there's any other. Our time is far spent. There's another question that just came up, sir. Maybe, Prof, sir, maybe you just take that question, and then I'll hand over to the SQ for the vote of
So
thanks.
somebody said, I remember a social media story about the hospital who didn't monitor ICP in a stroke patient. Your hospital should, your ICU should have protocols, policies, and other sets. Policies and protocols are based on evidence-based guidelines. If you develop an appropriate policy and sign it off with your clinical governance team, that's what protects you, and with reasons. For instance, the hospital does not have ICP monitors, even if it's guideline recommended. The people who make the decision come together and say, we don't have this capability. We cannot do this for patients who come in with ICHs or stroke. Based on the evidence or based on the reality, we can't. And then you have that as a policy. On the other hand, if you can, you say, these are the patients we can put it on. It's not for every stroke patient, or it's not for every ICH patient. It's your policy. People are going to say what they have to say. Sometimes a lot of people who say these things don't even understand what is involved in the management of these patients. But I believe what does you in is that you don't have policies and protocols and other sets. I cannot repeat it enough to say no ICU will function well without these three things. And if you start building and policies and protocols and other sets, you'll be surprised with the outcome in your ICU. Thank you, everybody.
Very much, sir. Thank you, sir. Thank you. We have really learned a lot from you, and then we hope that by the time the document comes, okay, Prof, sir, Professor Shinake, you are recognized, sir. You can go ahead and speak, sir.
Okay, thank you, moderator. Thank you, Professor Anyanwu, for that nice delivery. Very practical. I don't know what your experience has been with some patients that you have very refractory hypertension. Even with your labetalol, nifedipine, very refractory. I've seen quite some, and it's quite challenging. You have to combine a lot of medications. Do you have any experience about that, and what can be done? And secondly, is there any role for intracranial Doppler at all? Thank you.
So, Prof, thank you so much for that question. That's a great question, actually. So, remember how I said policies, protocols, other sets, and to be able to use other sets, to be able to use the guidelines based on where you practice. So I do have those patients. The guideline does not recommend, for instance, centrally acting blood pressure medications, such as alpha-methyl-dopa or clonidine. But I use alpha-methyl-dopa and clonidine in those patients with great success. The biggest problem with alpha-methyl-dopa and clonidine is mental status change. It's not that it doesn't work. It can make you a little bit drowsy. So in a lot of those patients with recalcitrant resistant blood pressure, that's what I do. And I do have them quite a bit from time to time. So it's a good one. And so that's what I do for those patients. Some of the older blood pressure medications work wonders. I recently saw a patient on Moderator. I don't know if the young doctors here know what Moderator is. It's really a diuretic, but nobody talks about them as much as the newer ones. Everybody wants to be on Novax. Novax is amlodipine. But those medications are still there and they work very well. And I recently encountered a patient who had been on it for years, more than 20 years, and somebody was trying to discontinue it. And I said, why are you discontinuing it? It works. And it controls the patient's blood pressure. So just leave the patient on it. It's the same story we have for rate control and management of heart failure with digoxin. Digoxin still works. So you don't have to use all the fanciful new things to treat these patients. So yes, I do use centrally acting drugs. I usually combine medication that work in different ways. So I have the ones that work on the adrenergic receptors, combine it with the peripheral vasodilators. I combine them with the diuretics, whether it's loop diuretics or thiazide diuretics. I combine it with, like I said here now, the centrally acting drugs if they are recalcitrant to regular blood pressure medication. I use that. And there's a role for intracranial Doppler, but it's a little bit complicated. It's best in the hands of somebody who really knows how to use them. So I'm going to skip that for now.
Thank you so much, Prof. Thank you for those. May I invite Professor Oshinake to please take our vote of thanks. Prof, sir, kindly take our vote of thanks for this. Thank you, sir.
Thank you, Dr. Salami. I want to thank sincerely our dear friend, one of us, Professor Ben Anyanwu. I almost couldn't recognize you. This your new look is super. So thank you so much for always being there, especially when it comes to this particular aspect. And I think it's so important because, as Dr. Job mentioned, this is, I mean, if not the #1 killer in Nigeria, it won't be far from it at all. So we can do this for as many times as possible so that we can help our society. Thank you so much for this. We are so grateful. Very soon we are going to be coming to Owerri again. For those who don't know, we'll be having a neurocritical care workshop, we're in May again at Regions with Dr. Anyanwu. Professor Anyanwu. He's always been there, and this is the 3rd edition. So I want to encourage everybody, if you want to know more about this aspect, please plan your schedule to be out to Owerri. Thank you so much. I want to thank all others who have joined this meeting. The attendance has been great, really wonderful. I mean, close to 150 people joined this meeting. That showed the importance of this topic we're considering. Thank you all for joining. I want to say great work to the Education Committee of the Society. Thank you all. I wish you a pleasant evening. Up to you, the moderator or the president. Thank you all. Bye for now.
Thank you, Professor Shanake. I really appreciate it. As you guys know, I can do this as many times as you want. Just in case you guys know, Dr. Job is always benefiting from this, from the backyard. So I'm willing to do this as many times as you guys request. I love to do this because I think it changes the paradigm of care and leads to better outcome. And with as regards my looks, when good things are happening to your life, you change your look. So I've lost a lot of weight. A lot of people don't recognize me when they see me on the road. And of course, grown a beard to add to that. Thank you for having me.
Thank you so much, Prof. We have really learned a lot. And thank you to our elders in the house. I don't know if the president, Dr. Job, the closing remarks. Yes, the closing remarks.
Oh, thank you very much. Thank you, Professor Ben Anyanwu. I mean, you've been extremely useful to our society. But I think there's something that I want to employ. Maybe I make an appeal to you. We should have a national guideline. It could be on how to manage both ischemic and hemorrhagic stroke. If you go to private clinics, go to public hospitals, people do different things. Nobody is looking at the evidence. Everybody just do what he or she likes. It's worse in private hospitals. And in fact, the patients get to us at tertiary hospitals more where we end up doing or managing secondary brain injury. That's what we do. That's why morbidity
We can't hear you, Dr. Joe. Thank you very much.
We have to see how we and local, a protocol how to manage this. If you can simplify it, that will be much better.
hear you, Dr. Job. What I have tried to do, by notice this is the first time I'm providing anything that sounds like a set. So this is the first time I'm providing anything that sounds like another set, and I've already said I'm willing to share it. We can start with something small. When I share it, please go back to your institution, look at the small things you do, what blood pressure medication you use, put it in here.
Please help assist.
Like I said, when the president shares it, go back to your hospital, modify it a little bit, put the blood pressure medications you guys use often there, put the name of your neurosurgeon there, put the name of your intensivist there. If you don't have a neuro ICU, just call it ICU. If you have Ward 1, admit. If you don't have a stroke unit, it can be Ward 1, you'd admit this patient, change the thing to Ward 1, make it to look like your own, get a little bit more evidence, but the most important thing, you must have evidence. Because you see, Nigeria is turning to something very interesting when it comes to lawsuits. So when they sue you, then you can say my evidence was based on this, not just based on eminence. It's based on this, or based on their small little trials, and then we can keep on improving on these things rather than we're waiting for when we're going to have a national convention to sit everybody down and provide an order set. But the other set I've just provided is an example and it's a template. The disclaimer is that you have to, it's based on evidence, but you have to work it based on what you people have in your hospital and own it, and then have your faculty or department approve it as what they're going to be using based on those evidence.
Thank you, Prof. Sir. I think we lost him. I don't know. We can't hear him again.
All right. So, well, I think at this point, I would say thank you, and I would say thank you and have a nice day, everybody, while I exit the presentation. Thank you. Enjoy your weekend. Have a great day. Bye-bye all.
Bye, sir. And we'll see you in July, sir, by God's grace.
Sure.
Bye, everyone. Thank you.
Goodbye, everybody. God bless.
Oh, the general is here. Sorry, I was locked out. General, good evening, sir. Or is it good afternoon over there?
My president. Good evening, my president, and well done for bringing Professor Anyanwu again. That was Dr. Salami. God bless you. Thank you.
Sir. Good evening, sir. Yes, sir. Thank you, sir. Dr. Rotimi. Good evening.
Professor Anyanwu is here with us as well. Prof, how are you?
Good evening, sir. Fine, sir. Nice to see you. Yes, sir.
Dr. Salami, well done.
Oh,
thank you for that great job.
Immediate past president, good evening. Mr. President, good evening.
My general, sir. Good evening, sir.
Yes. Professor Shinaiki has advertised your May